Good evening, sir.
Vinod, you can start.
Yes.
Ah,
Today I am presenting a case.
Vinod.
What happened?
Ah. Okay, so Vinod, wait. The case presentations are of many varieties. One case presentation is to demonstrate the clinical findings and then go about the differential diagnosis, investigation, and management. Certain others, the clinical findings are there, but not so obvious for the people who are listening. But then after the clinical findings are presented, then you concentrate on the differential diagnosis and investigation and management of such cases. So this is one such case, and Vinod is going to present it.
Yes.
Okay, Vinod.
Uh, 65-year-old female patient who is a resident of Bangalore, who is a housewife, came to the hospital with a complaint of bleeding per rectum since 20 days. And patient was apparently all right 20 days ago, then developed a bleeding PR, which is painless, which is insidious in onset, small in volumes, bright red in color, fresh bleeding in the toilet bowl while going for the defecation. And there is no history of any altered bowel habits, and there is no mass per annum. There is no history of pain in and around anus, and there is no black colored stools, and there is no history of abdominal pain or distension, fever or loose stools, and there is no urinary symptoms, and there is no history of weight loss or loss of appetite, jaundice, cough, or low backache. And patient is a known case of diabetes and hypertension, and she's on regular medications. For diabetes, she's taking metformin with glimepiride, and for hypertension, he's taking telmisartan. And personal history, she's taking a mixed diet, and she had regular sleep cycles and normal bowel and bladder habits, and no other habits like tobacco chewing or smoking or alcohol habits. And family history is not significant. And on summary, a 65-year-old female who came to the hospital with complaints of painless bleeding per rectum since 20 days. Can I continue, sir?
Yeah, did you talk about pain on defecation?
There is no pain, sir.
Go to that first slide.
See, other thing is you also have to say about was the bleeding along with the stools or after defecation?
After defecation, sir.
Vinod, what
Sir.
is that insidious onset of bleeding? How can you call that insidious onset of bleeding?
Sir, she recognized 20 days before, but we don't know actually exactly when it actually starts.
No, but that is not called insidious.
See, when patient notices bleeding, that is when she has noticed bleeding. What is insidious in it? What is the definition of insidious?
Exact.
Insidious means it comes on slowly and does not have obvious symptoms at first. But when she has bleeding, it will be an obvious symptom only. So it can't be called as insidious.
Okay, sir. Okay.
So it is not admixed with stools.
No, sir.
What is the significance if the bleeding is admixed with stools or if it happens after the process of defecation?
So generally upper GI,
Not upper GI, man. You are talking about fresh blood.
Yes, sir.
So does the blood drip after passing motions?
No, sir.
So it is along with stools. So you mean?
Yes, sir.
Blood comes along with stools.
Yes, sir. Yes, sir.
So what is the significance of blood admixed with stools and blood dripping after stool passage of defecation?
So, during defecation, if the stools are hard, it might rupture the mass or mucosal layer that will lead to the bleeding that will come along with stools.
No. What is the difference with respect to diagnosis based on that history what sir said?
Sir, generally fissures along with the stools, and in hemorrhoids before stools, and when there is a bleed higher up, that will come after the stools.
No.
No.
You're
If it is
completely
dripping, it is due to hemorrhoids
Yes, sir.
post this thing. So if it is along with stools, it is due to something higher up, which is coming along with stools. Fissure can be before or after also.
but fissure, the
Even in
bleeding is
hemorrhoids,
not significant at all.
it will be invariably associated with pain. Bleeding is occasional.
Yes.
So as you said rightly, the stools causes minimal mucosal trauma of the ulcerative growth, and that
Yes.
bleeding happens, and the blood mixes with the stools, and you get a bleeding along with the stools. But with hemorrhoids, after the stools have passed, that is when, as you said, the trauma to the hemorrhoidal cushions, mucosal surface gets abraded, and then there is bleeding.
Yes, sir.
Okay, so that is what is the significance of this. Okay, carry on.
General physical examination. Patient was examined after taking verbal consent in a well-lit room in the presence of female doctor with adequate privacy. Patient during examination was conscious and oriented with a KPS score of 90% and EGOG score of 1. And patient is moderately built and well nourished with a pulse rate of 84 per minute. Examined on the right hand brachial artery. BP is 128, 120 by 80. Examined on right hand in a supine position. Respiratory rate is 18 per minute and temperature is 98.6, and there is no pala, icterus, cyanosis, clubbing or pedal edema or generalized lymphadenopathies.
There is what is lymphadenopathies, generalized lymphadenopathy.
Okay.
That's all.
Yes.
Okay.
Go to the previous slide. Here, you need not have to mention female doctor. You say female helper was
Attendant.
there, attendant
Yes, sir.
with adequate for adequate privacy.
Yes, sir.
Okay.
Not necessary to have a female doctor.
Yes, sir. Yes.
If she happened to be a female doctor, that's okay, but she's still an attendant at that time.
Yes,
Or
sir.
a chaperone, female chaperone. Okay, carry on.
Abdominal examination. On inspection, abdomen is flat and skin is normal, and there is no hernial orifices looks normal, external genitalia looks normal, umbilicus inverted and centrally located, and there is no visible mass. And palpation, abdomen is soft and there is no tenderness and no distension, no mass felt and there is no organomegaly, and normal peristalsis felt on auscultation, and hernial orifices were normal, external genitalia were normal. And distal rectal examination, mass felt which is non-tender, hard, felt at the tip of the finger, which is bleeding untouched, and sphincter tone is normal, rectovaginal pouch and anal canal were normal. And
Vinod, 1 second. One second. We go back. You are saying you are saying mass felt at the tip of the finger. You are just touching the mass, no? So how did you feel the hardness or softness or firmness?
At the tip, what I felt.
Okay, very difficult. If it until unless you press and see and palpate and see, just saying that you're touching the mass, no, at the tip of the finger.
Yes, sir.
Okay, that is ambiguous. Okay.
And on proctoscopy, circumferential ulceroproliferative mass felt at seen at 8 centimeters from the anal which is bleeding. And
Wait. Circumferential ulceroproliferative mass. You mean the entire circumference of the rectum was occupied, is it?
yes, sir.
So the complete circumference.
Full circumference, sir, but still the canal is present, sir.
No, how can it be then?
If you have
You
a
mean
growth
the entire
which involves the entire rectum,
Yes, sir.
the patient should have obstructive features.
No, sir, there is no obstructive features.
No, you can't have a tumor which is probably it may be involving 60-70% of the circumference, not 100%.
I felt.
You felt all around?
He's seeing on proctoscopy.
Yes, sir, proctoscopy.
Are you seeing it all around the rectum?
Yes, sir, almost like 70 to 80% is.
No, then it is not circumferential if it is 70 to 80%. It is 2/3 or 3/4.
Okay. Okay.
See, we have told you many times, internationally it is called anal, not anal.
Yes, sir.
And how many times we correct you, again you go back to anal, anal. No, it sounds very terrible.
Sorry, sir. Sorry, sir.
Okay.
Bleeding seen from where?
At the distal end, sir, whatever we are seeing the terminal part.
Was it like a polyp or was it a ulceroproliferative mass?
It's like a proliferative, not like a polyp, sir.
No. Is it ulceroproliferative or is it proliferative or is it polypoidal?
Ulcers and there is nodule. I mean, nodules are present, sir.
Either ulcer or nodule. Both are different. Ulcer and or nodule cannot be there together. Can be there, but what did you see?
Both are there, sir.
What both?
Ulcers and nodules.
Nodules. Where?
Over the mass.
I don't know. Sir, can you describe as
You
nodules?
don't have a picture of proctoscopy, Sun?
No, sir.
Sigmoidoscopy or colonoscopy findings or anything? Okay.
It was done
Continue. We'll
outside,
see
sir.
later.
Yes. Systemic examination.
Nikita, sir, is sir joined or not?
Sir, join, sir, but
Nikita?
Sir, the audio no unmute ಇದೆ.
But he is not able to talk. Sir? Okay.
Sir joined, sir, but sir joined, but sir is unable to use that mute and unmute, sir. Some issue with that.
Okay.
Sir, now unmuted now.
No, he's unmuted for a long time, but he's not speaking.
Okay, carry on.
previous S1, S2 are present and there is no murmurs, and respiratory system, normal vesicular blood sounds survived and there is no added sounds, and CNS patient is conscious and oriented with a GCS of 15/15 and there is no focal neurological deficits. Summary: a 67 years old female came with chief complaints of painless bleeding per rectum since 20 days, and distal rectal examination, circumference 3/4 circumference has been covered mass, which is hard, non-tender growth in the mid rectum around 8 centimeters from the anal verge with bloody staining. Provisional diagnosis is carcinoma.
Why did you call that as mid rectum?
Sir, generally 4 centimeters will be the anus, and if it is the 12 centimeters rectum, it will be divided into one third as and it goes into the mid rectum.
No, you said the tumor is in the mid rectum.
Yes, sir.
But as per your findings, it is around at the 8 centimeter length.
Yes, sir.
Correct.
If anus is 4 centimeters and distal rectum is 4 centimeters, we are feeling at the tip, so I felt it as mid rectum.
No, which finger did you use?
Index finger, sir.
Index finger. How big is it? Like, what is the length of your index finger?
Around 8 to 9 centimeters.
Yours that big?
Yes.
Anyway, but a 7 to 8 centimeters will still be in the low rectum. You have to probably say low rectum extending into mid rectum. Sir?
I think the whole anorectum is about, what is the length of anorectum, Vinod? Anal canal and rectum.
Sir, around 20 centimeters, sir. 18 to 20 centimeters.
20 centimeters. So yes. The anal canal is 3 to 4 centimeters.
Yes, sir.
So the remaining 16 centimeters, 16 to 17 centimeters. So on that count, this will count as a low rectal tumor.
Okay.
Mid-rectum will be beyond that. So 10 centimeters upwards.
Yes, sir.
10 to 15 centimeters will be mid-rectum. 15 to 20 will be upper rectum.
Okay, sir.
Okay, so this will be lower rectum.
Correct. Okay, sir.
Okay. Now, are there any differential diagnosis?
Sir, we can consider a polyp, sir.
No, but you have said your
You
description.
yourself have said it is ulceroproliferative, not polyp.
Yes, sir. That's what only I can feel that one, sir. If it is otherwise, most of the
Then you justify your answer. You if you are described ulceroproliferative and you ask the examiner that it polyps, sir, you will be failed
okay, sir.
because you have all along mentioned it as ulceroproliferative.
Yes, sir. As a 65 years old female at that age with ulcerative proliferative lesion with bleeding PR, most probably it is carcinoma rectum, sir.
Any other tumor in the rectum which can manifest like this?
No, I think. No, sir.
No, you can. You have GIST tumors of the rectum. You can also have lymphomas, but generally they will be submucosal growths.
Okay, sir.
You may have subsurface ulceration, but not similar to what you have described, ulceroproliferative growth.
Yes, sir.
So the majority of the tumor will be in the submucosa. So you will feel it as a mass rather than you can have small surface ulceration, but not as a ulceroproliferative growth.
Yes,
So
sir.
usually it has to be and you said it is hard.
Yes, sir.
So we are not, the diagnosis may be obvious, but you have to be able to justify your diagnosis.
Yes,
Why
sir.
have you made the diagnosis of carcinoma rectum and not something else? So you should say the age of the patient and patient presenting with bleeding rectum, and clinical examination shows a clinical
Ulcer.
examination including digital rectal and proctoscopy shows an ulceroproliferative growth which is at around 8 centimeters from the anal verge, which feels hard on touch.
Yes, sir.
So for these features, I would like to think it may be carcinoma of the rectum.
Yes, sir.
Okay. So how would you investigate this patient to confirm your diagnosis?
Sir, I'll do colonoscopy, sir, first time.
Okay. What are the things you are looking for in a colonoscopy?
First to know the location, sir, and extend distance from the anal verge, and then is it pedunculated or fixed mass, or and then to go take a biopsy, sir. And there is no any other malignancies.
See, the things you are looking for in a colonoscopy is, as you said, the extent of the tumor, the distance from the anal margin to
Yes,
the
sir.
tumor, correctly define whether it is a mid-rectal or lower rectal tumor.
Yes, sir.
The extent, how far up does it extend?
Yes,
What
sir.
is the how much of the circumference is it involving? Does
Yes.
it allow the scope to be passed through?
Yes, sir.
And then and then does the tumor touch, bleed on touch? So these things you will be able to see.
Yes,
And
sir.
then you go up, and also you are looking for any other lesion. For example, is there any mucosal pathology which led to this tumor? For example, ulcerative colitis or something like that.
Yes,
So,
sir.
you should see the rest of the mucosa is normal. Are there any further polyps elsewhere, or as you said, synchronous malignancy
Yes, sir.
all the way up to the cecum? Okay, so these are the features you look for when you do a colonoscopy. And then you also have the added advantage of getting the,
Biopsy
again, where do you get the biopsy from?
from the margin, sir. Tumor with the normal tissue.
Tumor with the normal tissue, not from the core of the tumor.
Yes, sir.
Because as Niranjan said, with the other tumor, what happens? If you take it from the center,
Bleed.
what will you get from the center?
Necrosis, sir. Necrotic.
Huh?
Necrotic, more of the.
More, yeah, more of necrotic tissue. You may not get the tissue by sample,
Yes, sir.
which which will look at the tumor. So from the margin, including the normal tissue.
Yes, sir.
Okay. What else? Now you got the histology as carcinoma, adenocarcinoma rectum.
Yes, sir.
Can this be any other tumor? Can it be a squamous cell carcinoma?
No, sir. It is. No, sir.
Where is squamous cell carcinoma common?
Below dentate line.
Anal canal.
Yes, sir.
Okay. You can get rarely, but generally it is adenocarcinoma.
Yes, sir.
Okay. And what other investigations will you do?
Routine blood investigation, sir, and MRI pelvis and CT abdomen and pelvis and CT or chest X-ray of thorax.
Okay. So, what is the investigation of choice to stage the tumor itself?
Sir, for TN staging, MRI, sir. For METs, we required a CT abdomen and pelvis.
What are the features in MRI? What does MRI tell you?
Extent of tumor, sir, whether it is involving nearby structures or not, or serosa and perirectal, mesorectal involvement,
Hmm.
bladder involvement.
Hmm.
Yes.
What else?
In females, vaginal involvement in and
Okay.
yes. And
What else? What else will it tell you?
lymph node
Lymph node where?
in the mesorectum
And
the para-aortic and also
extra mesorectal nodes.
yes, sir.
So that is a one of the most important features.
Yes, sir.
See, previously they would say digital rectal examination is good enough for you to make a diagnosis and for you to assess the extent and the fixity of the tumor. It will give you no doubt.
Yes, sir.
Digital rectal examination has to be one of the important initial clinical assessments. But people used to depend on that and also examination anesthesia to assess the fixity of the tumor and all these things.
Yes, sir.
But the main thing which is now, in those days when digital rectal examination used to be the, investigation of choice along with other modalities that you said, CT scan of the abdomen and CT thorax maybe or chest X-ray, the local recurrence rates were very high because the only way to assess the fixity of the tumor was doing a CT of the abdomen and pelvis, and that was understaging the disease to a large extent. So since the advent of MR scan and all the features that you just described, it has made a significant difference in terms of local staging or assessment of the tumor. The mesorectal involvement, then nodes present in the mesorectum, extra mesorectal nodes, then contiguous structure involvement. All of these things. So the MRI staging before is very significant. Why is it significant?
Sir, the surgery, sir. Sir.
Sania, can you answer that question? Why is MR significant?
Sir, to decide about the surgery,
What?
to decide about the treatment protocol, sir. Next.
See, there is a lot of things that are happening with rectum.
Yes, sir.
What is NTN?
I'm not sure, sir.
What is wait and watch policy?
No
What
idea,
is
sir.
what is pathological complete response?
That is for chemotherapy. After giving radiation therapy and chemotherapy assessment, sir. Sometimes, most of the times after chemo radiation, it is proven that around 20% of the cases the tumor completely disappears. So
Correct.
then we take a
So
and
There
So
is
why-
something called total neoadjuvant treatment for rectal cancer, which is probably the sometimes the only modality of treatment which might be required, where there will be complete pathological as well as local response.
Yes, sir, yes.
see the importance, I think Niranjan is absolutely right. See the importance of MR is that what they did was a very dedicated and interested radiologist who was very dedicated about MR compared the reporting of the MR to the after the tumor was actually resected and pathological staging was done. So they superimposed the MR images to the resected images, and then they reported all the things that they were supposed to report, and there was a 97 to 98% congruence between what the pathologist had said in terms of the circumferential resection margin to mesorectal involvement, mesorectal nodal involvement, extra mesorectal nodal involvement, contiguous structure involvement, all of these things. So there was a significant concurrence or what we call as concurrence with MR and the final pathological resected specimen. So what that meant was, if you have a dedicated, the rectal protocol, which they do with the rectal coil, the MR scan is actually almost as good as your pathology. So you have a baseline pathology, a baseline MR scan, and then subsequently you can compare after you have given neoadjuvant chemotherapy, neoadjuvant chemoradiation, NTN, any of these things, and then if, for example, the patient's condition, let us say the patient is not fit for major resectional surgery, or patient is, if it is a low rectal tumor and patient does not want a stoma. So in such situations, a wait and watch policy can be done, but then your MR scan actually gives you that, the advantage, because it can accurately stage the disease. So that is why MR is the investigation of choice as far as the rectum is concerned. What is the role of transrectal ultrasound? Anybody?
It tells you about the involvement of the layers of the rectum.
Yes. What else does it tell you? See, I forgot to tell you the other major advantage of MR is it will tell you about especially for the lower rectal tumors, it will tell you the involvement of the puborectalis and the sphincter complex. So whether you will be able to salvage the sphincters, all of these information you will be able to get. So that is another important information that you can get using the MR scan. As far as the transrectal ultrasound is concerned, it is pretty good, as you said, in actually staging the early rectal cancers, and for you to manage them using what is called as local therapy. So there are many local therapies, what is called as the what is it? T8 transrectal TEMS, transanal endoscopic microsurgery. TEMS and this one. So you can do these things, and usually the endoanal or transrectal ultrasound is a good adjunct to actually detecting the early rectal cancers where the tumor has not spread beyond the muscularis mucosa. So that is the major advantage, because MR is far superior to transrectal ultrasound. Nobody does that as a evaluation of a locally advanced rectal cancer. So for early rectal cancers, you can use for endoscopic ultrasound. See, because even, for example, there are two types of lesions. One is the Hagit's, the polypoidal lesion, where the tumor is usually not in the stalk, but at the tip of the cauliflower polyp. And there are the flat lesions, the SM1, SM2, SM3. So these are lesions where it may be tubulovillous adenoma with early malignant transformation. But the advantage of transrectal ultrasound in these situations is that it will tell you the extent of the involvement, as you said, of the wall. And also there is about 8 to 12% lymph nodal involvement, which it may pick up. So that is the advantage of using transrectal ultrasound in early evaluation of early rectal cancers. Not so useful in terms of the locally advanced and the larger tumors. Okay. And what does CT tell you, Vinod?
Sir, whether any mets to the liver and lymph nodes other than pelvic lymph nodes which were involved in other organs.
Okay. And CT chest also to
Yes,
look at the lung metastasis.
Lung mets. Yes.
These are the two common, liver and lungs are the two common, solid organs that the rectum metastasis is. Niranjan,
Yes, sir.
anything to add to the investigations?
Nothing, sir. That's what. If it is sometimes locally advanced, and if they're planning neoadjuvant chemo and radio, probably a PET CT
Yeah.
for assessing meds,
Yes.
and
Okay.
also to assess response.
Yes. Okay. Other investigations, Vinod?
CEA, sir.
CEA.
Yes.
What is the
What is its
importance of
significance?
CEA?
Sir,
What is the importance of CEA?
to know the to follow up the patient, sir.
There are many importances. One is if the levels are normal or low, it may tell you that it is a non-secreting tumor.
Yes, sir.
So in which case, post-operatively, it may not be useful to do CEA.
Yes, sir.
If the levels are very high, then as Niranjan said, you have to suspect distant metastasis.
Yes, sir.
So then you do a PET CT. What is the advantage of doing PET CT in selected cases? Sania?
For the follow up.
Post-operative, sir.
No. Please understand the question. What is the importance of doing a PET CT in patients where there is, possibly a locally advanced tumor, and the
That is
features on
to-
MR are very bad. Actually, they say there is terminology called ugly also, which is very bad. So why do you do these things? Why do you do PET CT? Because you have a lot of money. See, the PET CT is important for you to, especially as we said, if the CEA levels are high, if the CT shows that there is, liver mets, possibly lung mets, and nodal involvement, and on MR, it is not, the picture is a very bad picture. Then what happens is you have to do the PET CT to see if there is distant metastasis apart from liver and lung also. And then after you give the chemotherapy and maybe radiotherapy to this one locally, then unless there is complete resolution of these distant metastasis, you have no business doing any surgery, because it is already a systemic disease. And what is the advantage of doing the surgery if the distant metastasis has not resolved? So that is the importance of doing an PET CT. So if the PET CT shows very significant distant metastasis, unless there is complete resolution of them, with your chemotherapy, then you can't contemplate surgery in these patients. So whatever you are doing is, at a level palliative. So that is the importance. Okay, so CEA, as you said, Vinod, if the
Yes, sir.
levels are high, it will go up even before clinical or radiological manifestations of tumor recurrence, either locally, what we call as pelvic recurrence, or distant DM, distant metastasis. Even before they clinically or radiologically manifest, the CEA levels go up. So when that is the case, you go after, you do a PET CT or something to pick up these early recurrences.
Okay,
So
sir.
that is the advantage of CEA. In the time of diagnosis, if it is normal or low, possibly it may not be helpful in the follow-up period.
Yes,
If it is very high, then you have to be suspicious of distant metastasis and then look for distant metastasis using a PET CT. So
yes,
these are the roles. This is the role of CEA
CEA.
in rectal cancer. Okay. Now you have this lady is not anemic, or
Yes,
let us say she's anemic. Will you transfuse her before surgery? How will you pre-optimize this patient? What are the things you look for?
Patient is whether fit for surgery because lungs and the
Yeah, go on. What are
whether
the things you look for?
whether the lungs and creatine, I mean kidneys were doing well or functionally well, because to
See, other thing your CT will tell you is whether there is any involvement of the ureters.
yes, sir.
Is there ureteric involvement? Is there any hydroureteronephrosis? So
Yes,
that is another important information you will get with the CT.
yes.
See, the important things you have to look for. Sania, or let us ask Nikita. Nikita, what are the things which you will pre-optimize before you take this lady up for surgery?
Sir, mainly clotting profile, sir.
Clotting profile, okay. First you go
BT,
for clotting profile or something else?
complete blood pictures.
In that, what is important? Complete blood picture.
Platelets, fat cell volume, and hemoglobin, sir.
So what is the significance of hemoglobin?
As she's having a rectal bleeding, we are suspecting anemia, sir, in her.
Right. So what levels will you be concerned? She's a 66-year-old lady who has got diabetes and hypertension. So what
Yes,
levels
sir.
will you
Then
be
8 is,
concerned? What is the cutoff mark?
if it is less than 8, will be concerned, sir.
Less than 8,
8 to 10 will be like alarming.
Sania?
But if you're planning for any surgery, minimum hemoglobin should be 10. No,
No. I think again you need to understand. See, you have to evaluate the heart as well. So if her heart is good, 8 is acceptable. If there is any cardiac illness, then 10 is what is required. If the hemoglobin is below 6, you certainly need to transfuse them before surgery. If it is 8, you have to arrange blood for post-operative or perioperative transfusion if required, depending on the blood loss. 8 is good enough for taking up for surgery. 6, certainly below 6, you have to transfuse. 10 if the patient has got cardiac issues. So that is the internationally accepted standard. Okay, so don't forget this.
Vinod, is there any issue with pre-operative transfusion with respect to post-operative prognosis or something in colorectal cancers?
Sania, can you take that question? It's a very good question.
no, I don't know.
Vinod, do you know?
I think sudden overload on the heart, sir.
No, nothing to do with that. Niranjan?
I think some papers have shown that those who have received preoperative transfusions tend to perform badly with respect to probably uh, uh, local recurrence or metastasis. I don't know what is the exact reason.
See, I think there is equivocal evidence. There are some papers which suggest there may be. Majority of the papers said they don't. So I think the stigma of transfusing peri and pre-operatively is slowly going away. I think more and more evidence suggests that though the immunology, see, the thing is, it is very logical. If it is a very big tumor, very vascular tumor, and if it is locally advanced, and if there is bleeding, then the patient is less likely to do well. So that is probably related to the technical aspects of surgery. They used to think that immunologically there used to be a problem. So if you transfuse the patient, the patient's immunology and the tumor biology would react, and they would have a less favorable prognosis. But that theory is slowly being, sort of, what shall we say, debunked. So I think now,
But still, we should have a high threshold for transfusion only if when it is required. Like as sir was telling like earlier, if it is less than 8.
Absolutely. You should definitely, you only transfuse if it is absolutely required. And as I keep telling people, if you need to transfuse 1 unit of blood, you don't need to transfuse. Understood? Students?
Yes, sir.
If you need to transfuse 1 unit of blood, you don't need to transfuse. If you have to transfuse, you have to transfuse more than 1. That is at least 2. Otherwise, you can manage without transfusion. So that is what you have to remember. So, so hemoglobin is one factor. And as Nikita said, clotting, of course, it's probably not so important, but because unless there is significant liver metastasis, clotting is not usually an issue. Third thing is albumin. You need to know what is the level of albumin. It generally indicates the general, nutritional, if in a patient like this, nutritional status of the patient. And then the third thing is the respiratory reserve. So how well the patient is preserved respiratory wise, maybe you need to improve that, especially if they have COPD or asthma or smoker or anything like that. You have to preoperatively stop smoking and also give them chest physiotherapy, incentive spirometry, and all these things. Optimize them as much as possible before surgery. Because what are the 3 important complications that happen after surgery, man? Vinod? What are the 3 things you are worried about?
Coming out from the anesthesia, sir.
No. These days that is not an issue. What are the 3 main things that you are worried about in the post-operative period? Nikita?
So anastomosis leak, sir,
Anastomotic leak, yes.
and atelectasis as it is a open surgery.
Even in laparoscopic surgery, atelectasis and pneumonia and chest infection, yes.
Yes,
And
sir.
then
So,
third
post
one,
bleeding, sir. Secondary bleeding.
bleeding, that is a standard complication.
More than bleeding, DVT.
Deep vein
DVT.
thrombosis and pulmonary embolism. And fourth is urinary tract infection. So these are the things you need to worry about. So improve the chest physio, chest compliance by improving chest physiotherapy and incentive spirometry. And anastomotic leak is dependent on many factors, but one of the things is nutritional status of the patient. So ensure that their albumin is good, and then hemoglobin is also reasonable. And then you have to take the measures to prevent DVT and pulmonary embolism. So these are the things you need to worry about. Now, this patient is 68, fit, and according to the MR, what is the MR say, man?
Sir, actually they did PET CT, sir, directly. They came out from outside.
No, you have not done an MR.
Yes, sir.
Okay, put up the
What did PET CT? No, go to blood also. Show the blood reports.
Blood results.
So HB is 14.5.
Yes, sir.
What is T protein? Total protein. Okay.
Yes, sir.
CA is 1.85 normal. Okay. Hmm. Albumin is normal, huh?
Almost, sir. 6 point.
Albumin.
Albumin.
Albumin is also same. 4 point is there, sir. It is fine, sir.
4 point. Okay.
Yes, sir.
Next.
Okay. Yeah, next.
They have done colonoscopy, sir. The report was not there with the patient.
Ah,
So, but
Okay.
biopsy, they came with the biopsy report of colonoscopy, which is moderately differentiated adenocarcinoma of rectum invading lamina propria.
Okay.
okay.
Next.
And ultrasound they have done, sir, which showed normal.
Normal. Okay. Next.
And the PET CT shows FDG uptake is seen in asymmetric circumferential wall thickening in the rectosigmoid and proximal rectum. Maximal thickness is 2 centimeters. With mild perilesional stranding and non-FDG avid few sub-centimeter perilesional lymph nodes in the sigmoid mesocolon and no FDG avid or enlarged pelvic lymph nodes.
Go down.
Yes, sir.
FDG uptake.
Is seen in the following abdominal lymph nodes: celiac and peripancreatic lymph nodes. Largest is 1.1 into 1.5 centimeters, and
Okay.
periportal and portocaval lymph nodes, and
Okay.
para-aortic, aortocaval, and retrocaval lymph nodes.
Okay. Next.
And the liver appears enlarged and shows diffuse fatty changes and no FDG avid, sir. And few right supraclavicular lymph nodes are positive.
So what
Okay.
is SUV max, man? What does SUV max tell you?
Sir, uptake which
Go to that previous SU max lymph nodes in this one, celiac and para-aortic and all. So all are very significant. Okay. What does it suggest then?
Sanya, what is SUV max?
Is the standardized uptake value of the dye that the FDG that is given, sir, which is directly proportional to the malignant potential of that particular tissue.
Correct.
So we know what does it signify?
mm,
What is the CT report now?
metastasis actually lymph.
So what is the stage?
Stage 4, sir.
Is there any lesion in the liver, man?
No, sir.
So what is the treatment for this now?
What is this FDG with hypodense lesion in segment 5 of the liver?
Non-FDG avid, sir.
What is that hypodense lesion? And see this right supraclavicular nodes.
Yes, sir.
The SUV max is very high, man, 6.2.
Yes, sir.
So all are metastatic nodes there.
Yes, sir.
Okay. Now, how will you manage this patient with this finding?
Neoadjuvant chemotherapy and radiotherapy, sir.
Okay.
And if these lymph nodes get decreasing in size, then we can go for the surgery because it might lead to the obstruction. Otherwise, palliative care.
No, man. Why will it lead to obstruction? If the patient responds to chemo radio, the tumor will melt.
Yes, sir.
So, what is the neoadjuvant chemoradiation that you are going to give?
Fluorouracil with folinic acid and irinotecan.
Not irinotecan, man. Is Swaroop joined or not?
No, sir, not at joint.
No, I think they won't give that. They will give capecitabine. In concurrency, they will give radiotherapy. 5 days a week, 5 days a week for 4 weeks. Okay, they will assess the response and then only they will go for the further this thing chemotherapy if it is required. Majority of the times the tumor can shrink through the following regimen.
See I think that is why I think you would have loved to have Swaroop. See from whatever studies I have looked at, if, for example, not irinotecan, it usually is oxaliplatin, and even bevacizumab is another one which is considered. See
for metastatic disease.
so there is two things. One is the neoadjuvant chemo radiation, which as Niranjan said is what we call as the long course radiotherapy. You give up to 50 grays over a period of 4 to 6 weeks, along with capecitabine as a chemo radiosensitizer, and also to look, to hit at the you can, if the patient is fit, you can even give 5-fluorouracil with glucovorin if you want, and in addition you can also give oxaliplatin or plus or minus bevacizumab. So this is the regimen, and then after you complete the radiotherapy, you continue to give chemotherapy. That is the principle of the NTN. So that you continue till such time that you contemplate surgery. So what is the ideal time for surgery after the completion of neoadjuvant
Radiotherapy.
chemoradiation?
Yes, sir.
What?
When will you do surgery? How many days post the completion of the treatment?
1 month, sir.
Not 1 month.
Why?
Sanya?
What is that reason? What is the reason? 1 month or whatever, you tell the exact time, and what is the reason you have to tell?
Sir, tissues will be very fragile because of radiotherapy. If you go
What
early,
fragile?
Sanya?
and chances of anastomotic leak because of
See the ideal. Niranjan, you want to tell them what is the ideal time and why you do that?
So ideally, it is, I think, 6 to 8 weeks you have to wait
Correct.
for
Absolutely.
the effect of radiotherapy to set in, destroy the cells, and also to go away.
Correct.
Because once you give radiotherapy, the effect will stay for some more time.
Correct.
And the cells, if you operate within 2 weeks, there will be, as you said, there will be excessive inflammation there. So too early, the radiotherapy effect will be there. And
Correct.
once the tumor cells will also still be active, and the chemotherapy, radiotherapy effect will also be going on. So you have to wait for 6 to 8 weeks. Ideally, operate after 2 months. Usually 2 to 3 months. Up to 3 months you can operate, but
Yeah.
ideal scenario will be to operate after 6 to 8 weeks.
So that is 6 to 12 weeks is the interval, as Niranjan said. That is 1.5 to 3 months. Preferably operate after 6 weeks, 6 to 8 weeks. So they have looked at various time factors in terms of. So the main thing that, as the two things which Niranjan mentioned and also Vinod mentioned, one is the pathological complete response. See, if for example there is PCR, then if you operate on them, then the long-term outcome, both in terms of the pelvic recurrence and distant metastasis, is good. Overall survival is also better if you do, after about 8 weeks, 6 to 8 weeks after the completion of the radiotherapy. So that is one. Second one is, as you said about the inflammation and fibrosis and everything. So if you wait for about 6 to 8 weeks, then that is the best time to go in and operate on these people. So beyond 12 weeks, there is no advantage. And so hence, that is the interval, 6 weeks to 12 weeks. But they have compared various time intervals. Definitely no advantage if you do it before or even after 12 weeks. So that is why 6 to 12 weeks is the interval. Now, what if there is complete pathologic response? What will you do?
follow up, sir.
Will you not operate on this patient? What are the advantages of not operating? What are the disadvantages of not operating?
Patient has to go through this surgery, sir, and there is a chance of anastomotic leak and these things.
Correct. So all the complications associated with surgery in terms of anastomotic leak, pelvic sepsis, or complications, morbidity, mortality,
Yes, sir.
which can be substantial to 2 to 3% mortality, morbidity of anywhere up to 15%. So significant morbidity, mortality. Yes, that is one. And what else?
chances, but without surgery, chances of recurrence will be much more.
That is what you have to comment on the. See, the thing is, pathologic complete response happens only in about 20 to 25%. The remaining 75%, it may appear to have responded, but then if you subject it to final histology, there will be evidence of tumor there still. So, which is why you will have to operate on these people, and this is why the PET-CT comes into play. If the PET-CT shows distant metastasis, then you cannot operate, because what is the point of giving complications to the patient if you are not curing?
Yes.
Unless patient has very significant local symptoms with evidence of bleeding or obstruction or whatever, which is unlikely, because you would have assessed these things before you subject the patient to. Let us say the patient is already obstructing. What will you do in these circumstances?
First, I will
Patient
do
has come to
surgery.
you with kind of obstructing tumor.
I will do surgery, sir, first.
What surgery? It's a locally advanced tumor, man. What surgery are you going to do?
Res-
Sania?
Sir, LAR.
Abdul is not there today, no?
No,
He's
sir.
gone to Chennai. Hello?
Not
sir,
there,
yes,
sir.
sir.
Servo interchange.
Abdul has not joined today, right?
Yes, sir.
No, sir, he's not.
Okay. So Sania, you are getting all the questions. So what if the patient has come to you almost in obstruction, potentially obstructing tumor?
Obstruction, I would do a diversion, sir.
Correct.
That is
Either
something
you
else,
do
sir.
a colostomy or what else?
Ileostomy also, sir.
Not ileostomy. Ileostomy will not be very useful.
You
Because-
either do a Hartmann's or you do a diversion colostomy, one of the two options. If patient is very sick, unfit, you can't resect, you do a diversion
Diversion.
colostomy
Okay.
proximally. Or you do a Hartmann's, you resect the tumor, bring out the end colostomy.
Yes, sir.
Or if the patient
Third,
has, if you look at the MR and it shows an upper rectal tumor, you could even consider stenting it. You can do a rectal stent and then give them chemo. The disadvantage of that would be that if the response is good, the stent may migrate, but then the obstruction will also be relieved by that time anyway. So I think either you can do a Hartmann's procedure, or you can do a diversion colostomy, or you can stent. You provided, see, the lower rectum you can't stent. It has to be an upper rectal or proximal mid-rectal tumor. Only such tumors can be stented. So you can put a metallic stent in, and so they're self-expanding stent, so they will relieve the obstruction. Then you can give them neoadjuvant chemoradiation. So what was done in this patient, man?
Sir,
Go on.
lower anterior resection with loop ileostomy, sir.
Okay. Did anyone of you ask why sir opted to do a low anterior resection with loop ileostomy without neoadjuvant chemotherapy or chemoradiation, when there is evidence of supraclavicular nodes and nodes in the pericaval and celiac and all those nodes? Sir would have had his reasons, no, why he has done this.
Yes.
Okay, I think Niranjan, 10:15 ಆಯ್ತು 10:15 ಆಯ್ತು.
Okay.
So we'll have to ನಾಳೆ ಇದರಲ್ಲಿ I think they should ask the questions in the clinic ಅಷ್ಟೇ.
ಇಲ್ಲಿ ಕ್ಲಿನಿಕ್ ಓಕೆ, ಬೆಳಗ್ಗೆ ಅಲ್ಲಿ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ರೆ ಆಯ್ತು ಅಷ್ಟೇ.
ಅಷ್ಟೇ.
We'll discuss there because sir ಇಲ್ಲ, ಸರ್ ಬೇರೆ ವಾಯ್ಸ್ ಇಲ್ಲ.
ಸರ್ ಕೂಡ
ಸರ್ನು ಕರಿಬಹುದು, ಸ್ವರೂಪ್ನು ಕರಿಬಹುದು.
ಅದೇ
We can discuss there.
ಅದೇ
ಬೆಳಿಗ್ಗೆ ಒಂದು 11 o'clock ಸರ್ ಬಂದಾಗ.
ಅದೇ okay. So
Okay,
we can discuss about NTN and all these things. Read up about that, man.
Yes, sir.
Okay. Okay, I think we'll stop here. I think Vinod, you presented well.
Yes.
Niranjan, comments on his presentation and
yes, ಅದೇ ಅದು anal ಅದು that those mistakes he has to avoid, otherwise it was okay.
okay. Sania, what do you think?
He presented well, sir.
What do you think of the class? Did you learn anything?
And I did, sir. A lot of things I didn't know.
Okay, so I
I
think
did learn.
all of you, the homework is all of you please go and read up about all of these things. The role of MR, then assessment of these rectal tumors, preoperative, optimization, the principles of, low anti-resection. Let us not know, I think there's a lot more to be discussed. And then what is NTN, what is chemoradiation, what is pathologic complete response, wait and watch policy. There are lots of things for you to go and read up. Not in textbooks. Textbooks, you may not get all the information in the journals. Okay? Right. Good night.
Good night, sir.